Good afternoon to Ms. Shahida and my fellow friends. So today I will proceed with the chest wall anatomy. Okay, so the chest wall anatomy, I'll be speaking about the skin, the subcutaneous fat, what are the blood vessels, the lymphatics, the nerve from the bone, the thoracic cage and the cartilage and the muscles around the intercostal muscles. And also I will be talking about the endothoracic fascia, which is a connective tissue between the inner aspect of the chest wall and the costal pleura. Okay, so the thoracic cage is actually the bony part of the thoracic wall, which consists of 12 thoracic vertebra. It has 12 pairs of rib cages, well as the sternum. Okay, so the boundaries of the thoracic cage, behind it, it is the body of the 12 thoracic vertebra with their intervening disc, and you have the posterior parts of the rib. And in front, it is covered by the sternum and the anterior part of the rib and their costal cartilages. So the ribs, there are three types of ribs, which is true, false, and floating. The first rib to seventh rib is known as the true rib. Rib number 8 to 10 is known as the false rib. Actually, 8 to 12 is known as the false rib, whereby rib number 11 and 12 is known as the floating rib. And ribs are flat curved bones with high resilience. I have explained in my next slide why do we call it true rib. So features of a typical rib: a rib has a head with two articular facets. It has a neck which connects the head together to the body. And then it has a tubercle with articular and non-articular parts. There's a shaft and body of the rib, which has the costal groove for the blood vessels and angle. So the first rib will articulate with the T1 vertebra, and the last two ribs also, they will all articulate with their own vertebra. Okay, so this is a picture of a typical rib where it has head with two demi facets, the neck which connects the head to the body, the tubercle, the shaft of the rib, where there is the costal grooves at the inferior border, the angle, and the anterior end. So rib number 3 to rib number 9, they are called typical ribs. Okay, so the atypical ribs are rib 1, rib 2, rib 10, 11, and 12. And the reason why these are called atypical ribs, because they do not have the common features of a typical rib. Rib number 1 is shorter and wider compared to other ribs. It has only one facet on its head for articulation with its corresponding vertebra. And on the superior surface, it is marked by two grooves which make way for the subclavian artery and also the subclavian vein. Rib 2 has two articular facets on the head as a normal rib, but it has a roughened area on the upper surface where the serratus anterior muscle attaches to this part. Rib number 10 has only one facet for articulation, and rib 11 and 12, it has no neck and only contain one facet for articulation with their corresponding vertebra. Okay, so what is so special about the first rib? Okay, the first rib is the highest rib. It is the shortest, it is the strongest, flattest, it is the most curved, and also it is the most fixed and broadest. Okay, the shaft of the first rib is actually placed in a way that it slopes obliquely downwards to the sternal end. It has only one facet on its head for articulation with the corresponding vertebra, and the upper surface of the rib has two grooves for the subclavian artery and the subclavian vein, and these two grooves are separated by the scalene tubercle, which is a place for the attachment of the scalene anterior muscle. The first rib does not have an angle and it does not have the costal groove. Okay, so this is the first rib and the second rib. the clinical correlation with the first and the second rib, in case there is a fracture of the first rib, we have to think of great vessel injury, or mainly great vessel injury, because the first rib does not usually fracture. If there is a fracture, means the trauma has a high impact. And the thinnest and the weakest part of the first rib, it is actually at the groove where the vessels are situated.
Okay, so first rib, go back, Nima. Okay, first rib is, like you said just now, is the strongest rib. Okay, so any fracture to this first rib, you must always think of severe impact, high impact, okay, high impact injury, because of the relation with the vessels. So in case of patient that comes with let's say no other ribs fracture, only the first rib, this patient need to be admitted, compared to any other ribs that only single fracture you can discharge, isn't it? But first rib fracture, all must admitted to the ward. You must look for vascular injury. Okay, for vascular injury. Okay.
Okay, the second correlation is regarding the cervical rib, which can actually cause a thoracic outlet syndrome. So this cervical rib is an extra rib which arises from the C7 vertebra. It is present in 1% of people. This presence of this rib actually causes pressure on the lower trunk of the brachial plexus, which can cause pain along the medial side of the forearm and the hand, and also causes a wasting of the small muscles of the hand. Not only the brachial plexus, because it is also a part where the subclavian artery and the vein passes. So exertion of pressure on the subclavian artery can interfere with the circulation of the upper limb. So in my next slide, I have showed an X-ray which shows the C7 vertebra. So this is the cervical rib. Okay, I will move on to the sternum. The sternum is a flat, vertically elongated bone that forms the middle anterior part of the thoracic cage. It is divided into three portions, which is the manubrium, the body, and the xiphoid process. The manubrium has three notches, which is the jugular notch, the clavicular notch, and also the costal notch. Okay, so the important landmark for this sternum is the manubriosternal joint between the manubrium and the body. It is also known as the sternal angle or the angle of Louis. Okay, this angle is formed by the articulation of the manubrium with the body of the sternum and can be recognized by the presence of a transverse ridge on the anterior aspect of the sternum. Okay, this ridge is at the level of the second costal cartilage, the point from which all the costal cartilages and ribs are counted. The sternal angle lies opposite the intervertebral disc between the fourth and the fifth thoracic vertebra. So if we actually draw a straight line from the sternal angle behind, it actually reaches in between the fourth and the fifth thoracic vertebra. And this is a very important landmark, which I have explained on my next slide. So why is this angle of Louis so important? Because the ribs are counted from this level. Okay, at this level, it is known as the second rib. So when you want to count the ribs, you can start from this level. It also marks the plane of separation between the superior and inferior mediastinum. Above this landmark is the superior mediastinum, and below this landmark is the inferior mediastinum. And this is where the ascending aorta ends. It is the beginning of the aortic arch. The aortic arch begins and also ends, and it's the beginning of the descending aorta. And at this level is also where the trachea divides into two principal bronchi. The azygos vein arches over the root of the right lung and it opens into the superior vena cava. The pulmonary trunk divides into two pulmonary arteries below this level. The thoracic duct which crosses from right to left, reaches the left side at the level of the sternal angle. It is also the upper limit of the base of the heart, and the cardiac plexuses are situated at the same level. So there are actually 10 important points or significant landmark of the angle of Lewy. Okay, I will move on to the opening of the thoracic wall. There is two, which is the superior thoracic aperture and the inferior thoracic aperture. So the superior aperture consists of the body of the vertebra. You can see there's a red line on top. So that is the body of the vertebra of T1 posteriorly. Medially, there's margin of rib number 1 on each sides, and anteriorly is the manubrium of the sternum. Okay, this superior margin of the manubrium is a horizontal plane between the intervertebral disc of vertebra T2 and T3. And the first rib, as I've said before, it slopes inferiorly from the posterior articulation with T1 vertebra to the anterior attachment to the manubrium sternum. So the plane of the superior thoracic aperture is at an oblique angle facing somewhat anteriorly. Next slide. Okay, so this is a view from the top. This is the superior thoracic aperture, and these are the contents that you can see from the top. So there is the yellow color is the epiphysis of the right and the left lung. Okay, then you have your brachiocephalic, subclavian arteries and veins, brachiocephalic, subclavian arteries and veins. The trachea is in the center. Okay, behind the trachea, there's esophagus. Okay, and then there's the vagus nerve, sympathetic trunk, and also the phrenic nerve. Next, we move on to the inferior thoracic aperture. Okay, so this inferior thoracic aperture is actually closed by the diaphragm, and the structures passing between the abdomen and the thorax pierce or they pass posteriorly to the diaphragm. Okay, so we have the body of the T12 vertebra posteriorly, and then the rib number 12 and the distal end of the rib number 11 posterolaterally, and then the distal cartilaginous end of rib 7 to 10, which unite to form the costal margin anterolaterally, and finally the xiphoid process is anteriorly. So the xiphoid process is actually situated a bit higher than the posterior border. The joint between the costal margin and the sternum is roughly in the same horizontal plane as the intervertebral disc between the 9th and the 10th vertebra. So it's slightly higher. Okay, then I will move on to the intercostal space and muscle. So the intercostal space is actually the space between two ribs, adjacent ribs, and each space contains 3 muscles. So there is the outermost will be the external intercostal. In the center is the internal intercostal, and the innermost is the innermost intercostal. So the important point here is the vessels and nerves, they run in between the internal intercostal and the innermost intercostal, and they are arranged from superior to inferior. They are arranged in vein, artery, and nerve in that form, from superior to inferior, vein, artery, and nerve, and they lie in the costal groove. So, but there are also some smaller collateral branches from the intercostal nerve and artery which travel along the superior border of the rib below. Okay, so the external intercostal muscle, it is attached from the lower border of the rib above to the upper border of the rib below, and it runs in a downward and medial direction. It is supplied by intercostal nerve, and it acts to elevate the rib during inspiration. The next site is the internal intercostal muscle. It is from the costal groove of the upper rib, and it inserts into the inner lip of the upper border of the lower rib. And this muscle runs in downward and lateral direction. So in this picture, I've actually showed how does the fibers run. The external runs downward and medial direction, and the internal runs downward and lateral direction. Okay, next I will be speaking about the endothoracic fascia. Okay, the endothoracic tissue at the inner aspect of the chest wall is between the parietal pleura and the innermost intercostal muscle. And this fascia is actually continuous with the internal investing layer of the fascia in the abdominal cavity, which is the transversalis fascia. Okay, the suprapleural membrane, or also known as a Simpson's fascia, is a dense facial layer which is attached to the inner border of the first rib, to the costal cartilage and the transverse process of the C7. So in this photo, the Simpson's fascia is the one in purple. So what is so important about this fascia is that it gives a rigidity to the thoracic inlet and prevents the neck structures from being puffed up and down during the respiration. This Simpson's fascia can be damaged or injured during a neck surgery, which will result in a development of pneumothorax on the same side. Okay, next I will move on to the blood supply of the chest wall. So typically the intercostal space contains of 3 arteries. Why we say 3 is because one will run posteriorly, which is known as the posterior intercostal artery, which actually originates from the aorta, the thoracic part of the aorta. And this posterior intercostal artery, we have 11 pairs in total. And anteriorly, there are two arteries, which is 2 anterior intercostal arteries. One comes from the internal thoracic artery, which comes from the subclavian artery for the upper 6 spaces. And then for space number 7, 8, and 9, the musculophrenic artery gives the branches. So, but then the last 2 spaces below, there is no anterior intercostal artery. So the anterior intercostal artery is only from the upper 6 up to intercostal space number 9. At the back, the upper 2 spaces are supplied by the superior intercostal artery, which is a branch of the costocervical trunk, which is also a branch of the subclavian artery behind the scalenus anterior. Okay, so venous drainage also, it follows the arteries. The anterior intercostal vein drains into the internal thoracic vein and then into the subclavian vein. And the posterior intercostal vein drains into the azygos, hemiazygos, accessory hemiazygos, and also the brachiocephalic. So actually from this diagram, you can see, okay, the first intercostal, which is known as the left supreme intercostal vein, it drains directly into the left brachiocephalic. And then from the second and third, it goes into the left superior intercostal and into the left brachiocephalic. Whereas those from 4, 5, and 6, they go into the hemiazygos and accessory hemiazygos. Okay, I've showed this picture of the venous drainage in my next slide. Is a bigger picture. So yeah, so the you can see the left supreme intercostal, which goes directly into the brachiocephalic. Then the second, third, and fourth from the superior intercostal, and it goes into the brachiocephalic. The ones below enters the accessory hemiazygos. And then finally, number 9, 10, and 11, it goes to the hemiazygos. Okay, the lymphatic drainage of the thorax is actually divided into 2, superficial and deep. The lymph vessels from the skin of the anterior thoracic wall and the posterior thoracic wall, they will drain into the anterior axillary nodes. Anterior will go to anterior, posterior will go to posterior, and they will also go to the superficial inguinal nodes. Whereas those from the deep vessels of the intercostal spaces, they will go to the internal thoracic nodes along the internal thoracic vessel, and they will go to the thoracic duct on the left side and the bronchomediastinal trunk on the right side. Those on the posterior parts will drain to the posterior intercostal nodes lying near the head of the ribs to the thoracic duct. Innervation of the thoracic wall. So the intercostal nerve actually supply the skin, the ribs, the costal cartilages, the muscle, and also the parietal pleura. Okay, from the 7th to 11th intercostal nerve, it supplies the dermatome and the muscle of the anterior abdominal wall and parietal pleura, both the thoracic and also the abdominal wall. The branches over the anterior superior region of the trunk, these receive from the supraclavicular branch of the cervical plexus. It is from the anterior ramus of C4. So the highest thoracic dermatome on the anterior chest wall is T2, which this T2 extends into the upper limb. And in the midline, the skin over the xiphoid process is innervated by T6. So clinical correlation from the intercostal muscles is the chest tube insertion. So the position for the chest drain or chest tube is determined by the safety triangle, and the location of the safety triangle is actually the anterior border of the latissimus dorsi, and then from the lateral border of the pectoralis major muscle, and a horizontal line at the 4th to 5th intercostal space, where the apex being below the axilla. Okay, so when we insert the chest tube, we should be careful of the neurovascular bundle which runs in the superior aspect of the intercostal space, meaning that you should place the tube on the superior border of the lower rib, the lowest position of the intercostal space.